To Health by Place. My name is Brooklyn Larimore, and I'll be your moderator for this evening. Real quick before we get started, there is a parking validation code. You enter it into the kiosk in the garage. You can do it before you exit your car from the garage, but that is 1, 2, 3, 4. So do that, and your parking will be covered. And also, if you've not already, please scan this QR code to take this quick survey for us relevant to the conversation today, just so we can kind of look back at this afterwards. Housekeeping item 2, the restrooms, you can either exit through this door to the left, it says access to restrooms, or you can go out and around, but feel free to use the restroom whenever. There's also food. Feel free to go get that whenever you please. My name is Brooklyn Larimore again, and I work with Omaha by Design, the region's hub for people-centered urban design and policy. And tonight's event, Health by Place, is part of a larger series called Conversations by Place. And that's where national and local experts explore how the built environment shapes an aspect of our lives, such as health. And this event is brought to you by Make Omaha, which is the community engagement effort behind the City of Omaha's new comprehensive plan. And so before we get into our presentation tonight, the Health by Place of it all, I would like to share more about the comprehensive plan, because that's ultimately why we all are here tonight. And so a comprehensive plan is essentially a city's 20-year mission, a document that guides land use decisions, zoning, and public investment. And so this document really shapes what our city looks like, how it feels like, how we grow over time, and ultimately just what we do for the next generation. And this process is required by Nebraska state statute, as well as Omaha City Charter. And as of this year, we actually have not done a comprehensive plan in 29 years. It's been a really long time. Does anyone in the room remember what Omaha was like in the 1990s? A few? Okay, I do not know, but I probably know, and you guys can confirm that Omaha today and our population, what it looks like, what our priorities are, what our opportunities are, look a lot different than it did in the 1990s when the last plan was imagined. And so it's time to make a new plan, but one that by design ensures that it's building a future where everybody in Omaha has access to a safe, healthy life. That is a pretty easy thing we can do, right? Well, it takes a really big team. And so We Make Omaha is made up of many partners, one being the City of Omaha's Long Range Planning Department, another one being Omaha by Design, my organization, as well as SPARK, the Latino Economic Development Council, and Elevate Omaha. And there are several of these partners in the room tonight, so if you or your organization are a part of We Make Omaha, will you raise your hand real quick? Big round of applause for these people, all the work that they're doing to make this thing possible. One special shout out to Isabel Fleming from Omaha by Design, because where I dropped the ball, she caught it for this event. So I really appreciate the things she did to make this happen. But those are the people, after this event, you want to learn more about We Make Omaha, please reach out to them, including myself, if you have more questions. So far in this community engagement process, we're about 2 years in for We Make Omaha, and we're about to enter scenario planning section of the community engagement, and then plan development will start later this fall. And so far to date, we've gotten over 52,000 unique community comments that helped us develop our guiding principles for this process. And these are essentially just the aspirational values that will anchor the plan's direction and ensure that it's actually grounded in a community vision. And you might have seen some of those principles on the slides cycling when we first got in, but they are things like affordability and choice, public health and safety, and belonging and ownership. And again, these are not values that me and the We Make Omaha team just made up. They are grounded in true community vision and what you all have said you wanted to see for Omaha's future. And I'm going through this engagement piece really quickly because we have not that much time to get through that. But if you want more information, you kind of want to learn more about the engagement activities we have done to date and what some of that data looks like and what's to come, please visit wemakeomaha.org for more information. That website goes in a lot more depth than I am right now. So when you think of a plan, you might go straight to like land use and built form, and that makes sense. That's usually what we hear about with comp plans. But it is called a comprehensive plan for a reason. And that's because it does cover a lot of other element areas, such as arts, culture, and preservation, economic development, and housing. So the built form and land use is just one element among many. But since it is a land use plan, we do want to have in the land acknowledgement statement right now, especially before I talk about Omaha a little bit more, because this is a huge part of Omaha's future, or history, I should say. But there are several tribes who call this place their ancestral home and their current home, and we acknowledge their sovereignty and their purpose and part in this plan and engagement process overall. So now a little bit about Omaha. With nearly 500,000 residents in the city proper and about 1 million in the metro Omaha area, we have quite the sprawl across our 146 square miles, which means we just have a lower density overall. And what this means, what this sprawl means, and I'm sure you all have experience as you're driving and going through the city, is that we are approaching a genuine crossroads with what we can do with how our city's growing. So what this means is if we continue to grow now, which is outward rather than upward, like we have been since the 1960s, then we'll actually run out of developable land within the next 30 years. So this becomes very important when we're looking at building this new comprehensive plan for the next 20 years, if this is a dilemma we have within the next 30. And let's visualize this real quick. So this map, this is Omaha. The teal areas are areas that are developed currently or will be developed. It's the white areas that is considered available land. But you see that it's all within this orange box, those squiggly lines. What that is our growth boundary areas. And so we cannot go outside of those boundaries. So that means north, south, can't cross county lines. We can't go east and take over Iowa. And that squiggly line in the west, that is called the Elkhorn Ridge Line. And that essentially just means the topography changes so much where we can't put like sewer lines and things in that area to even be able to develop. So we're working within that box. And given the 30 years to how we're going now, questions like, how do we grow to address this? What would growth like if we made these changes? All these are very important questions to ask now, but they're not just planning questions. They're also health questions. So when a city decides to put a bus route in a particular area, decides where things can be zoned at or where we invest in infrastructure, it's not just the technical decision that someone's making. It's also a decision that impacts whether someone can get to their job or whether or not they can purchase the type of home that fits their needs best, or whether or not they have a grocery store in their neighborhood. So these things, access, mobility, stable housing, are what we call vital conditions. And they play a very important role, predictive role in health outcomes, depending on where they are in the environment. So tonight, I'm about to introduce our speaker. And we're going to be looking at a lot of data here shortly. And when you look at these maps and look at this data, I want you to see these things as not being coincidences, but rather consequences of previous decisions that have made in the city of Omaha that we see today. And so what this means is that right now, as we're embarking on this comprehensive plan process, I'm not saying that as many times as we have to, but it means that all the decisions that we're making now have the power to influence the chronic health outcomes, life expectancy, and overall quality of life for the next generation of Omaha. So planning decisions are health decisions. So that means this comprehensive plan document we're working on is not just a land use document, but it's also a public health document. So without further ado, please let me introduce you to your speaker, Leah, with the Douglas County Health Department, and she'll be speaking to you tonight about the Community Health Improvement Plan data and what this means for planning.
My hands figured that would be easier. So, welcome everyone. My name is Leah Casanave, and I am the Division Chief over at Douglas County Health Department, and I oversee our Division of Community Health, Nutrition, and Clinical Services. So, I'm really excited to be here tonight. I want to thank Brooklyn for bringing all of us together. I think we've got a really fun evening to share for you. All right, so I'm not a super visual person, but I'm going to ask you guys to kind of visualize with me for a minute. So let's think about the world that we want to live in, and a world that supports us every single day. It's a place where our water is safe, our homes are shielded from environmental hazards as we start to enter tornado season, and our energy is clean. It's a community where individuals have access to stable housing and the opportunity to thrive. So this is something that I think everyone can get behind. It's built on a fundamental right to live free from environmental harm. And then when we have green spaces for play, well-stocked grocery stores, safe sidewalks for everyone to walk around in for their evening stroll, our daily routines are transformed. And these aren't just conveniences. They are the building blocks of our physical and mental well-being. So the mission of public health is to turn this vision into a reality. And by preventing disease and injury, we promote safer, higher quality lives for everyone. And our goal is to ensure that every person has the facts and resources necessary to make those informed, healthy choices, and for themselves, for their family, and even for their community members. So we're going to do a little history dive here. And most of us can say that safe water probably is something that we take as just common sense today, but it was once a radical idea. So there's a mystery that occurred in the mid-19th century, and it saw a terrifying cholera outbreak in London. And the prevailing theory was that it was miasma, which is bad air. And Dr. John Snow was skeptical of this and believed that the culprit was actually the water supply. So to prove his theory, Snow mapped the deaths in the Soho district, and the data revealed a massive cluster centered directly around the Bride Street water pump. His investigation grew more precise when he noted that the brewery workers, coincidence? I think not, drank only the malt liquor and were actually healthy. So Snow convinced the local parish to remove the pump's handle, and the outbreak immediately subsided. So this was more than just a medical victory. It was a birth of modern epidemiology, which is why we call John Snow our father of epidemiology. And Snow showed that public health is about designing a world where it's easier to stay well. The core concept really is established was that data visualization is a tool for urban intervention, proving that the built environment, and here specifically the water infrastructure, was a vector for the disease. So John Snow's radical act was to treat patients without pills, but rather treat the city by disabling the faulty infrastructure. And so that just proved right there that urban design is part of public health. So if we're going to continue down this path, John Snow's investigation basically proved that how we build our environment affects our health, and making this clear permanent connection between the urban design and public well-being. And it really comes down to three main ideas: that infrastructure is healthcare. So the key systems like pipes, sewers, trash collection, those are non-negotiables for us. And in Snow's fix wasn't medicine, it was prescribing a change to the city's infrastructure. And as you saw on the previous slide and in this one here, mapping matters. But just like Snow charting the cholera deaths, we now use tools like our life expectancy data to spot the gaps in our environment that lead to illness and hopefully stop it before it even starts. And then lastly, the policy is design. So things like zoning laws, how safe our sidewalks are, where the grocery stores end up, are all deliberate design choices. And they either help people thrive or they can be places where disease can actually enter in. So if we're looking into Omaha, what are our actual pump handles? Think of things like food deserts, not enough shade, sidewalks, grassy spaces, where it makes it tough to get around by car. But by changing the plan and removing these systemic barriers, we are not just planning the city, we're designing this healthcare system for us. And then also recognizing that zip codes really do remain some of the strongest predictors in our health. So with that, if I hit to or on my slide, we can look at our life expectancy map that you can actually visit on the Memphis County website. But diving into this deeper notion of zip codes and how they're predictors for our health. So the data that is up here is a 5-year average from 2018 to 2022. And the county average life expectancy is 78 years. However, there are some gaps and there's some disparities really between our zip codes here. So while we have parts out in West Omaha that hit the mid 80s, I want to say, I think it's 81 to 84.5 for that region. We also have over in our Northeast Omaha area that is in the low 70s. That is a 10-year plus difference in lifespan between neighborhoods that are really only a handful of miles apart. So if snow were around today, he would just be tracking the backwater, if you will. He'd be checking out these dashboards to find the root causes of what these social determinants of health are. So we use these death rates and the life expectancy maps to show us where those community systems are failing. And if a census tract has a lower life expectancy, it's a big warning sign that the local environment, maybe that's lack of parks or air quality or no nearby healthy grocery stores, is letting its residents down. So as Brooklyn kind of started touching on this with the vital conditions, I wanted to showcase the difference between what some of us in public health call the social determinants of health and what a lot of planning organizations use for vital conditions. So social determinants of health are basically the non-medical things: economy, social norms, climate change, and these shape where and how people are born, how they grow up, they work, live, and as they get older. These are the big picture things that really drive health outcomes. Think of education, our healthcare, neighborhood, the community vibes, and financial stability. But then we have our 7 vital conditions, and this is a neat framework that public health and planning folks use to organize and tackle the big challenges that are identified to the social determinants of health. And these vital conditions categorize what's necessary for people to truly reach their potential. And they're meant to connect those public health goals, like the social determinants of health, to development decisions. So think of our SDOH, the social determinants of health, as the tool for diagnosing the problem. They identify the areas like financial stability, access to care, social context, the root causes of poor health, and the vital conditions framework is the organizational map for planning and implementing the real system-wide changes that fix those root causes. So to kind of get into a little bit of the meat of what we're going to be talking about, the Community Health Improvement Plan is designed really with the Metro Omaha Regional Health Council, which we have some friends here that help us facilitate that with the well-being partners. And the Omaha Metro is the Douglas County, it is Sarpy-Cass counties, and Potawatomi County. So the Community Health Improvement Plan is a long-term systematic effort that addresses public health problems based on the results of the community health assessment. And this plan is an actionable 3-year plan outlining its goals, strategies, and performance measures. So our Metro Regional Health Council is a collaborative group, as I mentioned, led by the well-being partners. It includes local government, healthcare systems, nonprofits, federally qualified health centers like One World and Charles Drew. And in addition, we also utilize voices from the community to help direct the strategies and goals. So it's really a community-wide agreement. And all of the priorities that are in the CHIP are backed by the local data, which can range from those chronic disease rates to also social determinants of health like housing and transportation. So how did the CHIP get here today? What's the roadmap for developing it? So it follows the framework called the ACHI-CHA toolkit, which is this image on the right. And it's a nationally recognized model that provides a structured, collaborative, and equity-centered approach to understanding the community needs and guiding the regional health improvement efforts. So this framework includes 9 steps, and it takes communities from partnership development through long-term evaluation. The approach ensures that assessment and planning are data-driven, community-informed, and aligned across multiple sectors. So the 9 steps of it are building relations, developing community profiles, increasing equity with data, prioritizing the needs and assets, documenting and communicating those results, mapping the development processes, planning equity strategy, developing action plans, and lastly, evaluating the progress. and the really fun pieces, then you do it all over again. So the timeline specifically for what we've utilized here is in about the summer, fall 2024, we collected our CHA data, the community health assessment, and there was over 3,600 individuals surveyed for this data. In February of 2025, that CHA data was published. So once it was published, we actually took it to the streets, if you will, and had community conversations. In the spring, we had approximately 54 community members attend those. So through those, in the summer of 25, draft priorities were created with the Regional Health Council. Following that, the environmental scan was completed and was sent out to over 700 community organizations. So in the late fall of last year, there was a draft chip that was shared with the priorities, and hopefully here in the next month, I believe, that chip will actually be published. So what you guys are going to be seeing it's hot off the press, still in the almost final draft form. So what's the purpose of the chip in city planning? How are these two things? Why are we talking about this? So the whole thing is really shifting our focus from just treating people once they're sick and actually creating healthier communities in the first place by getting at those root causes of health. So we use the chip to figure out the biggest needs, like maybe mental health support or better access to food, so that we make sure county and city money goes to the places where it will make the biggest difference. For city planning, this can mean we use health data to make smart decisions about things like making neighborhoods more walkable to help prevent chronic diseases. Update the zoning so that we can have healthy food in our food deserts that we have here. And then understanding that having safe, affordable housing is the key to mental health and community stability. The best part of the chip is it also sets up a shared way to track our progress, so the whole community can see that the health initiatives are actually working. So through the collaborative priority setting process that brought together these public health experts, healthcare systems, federally qualified health centers, we had really three major priority areas. The first one being mental and behavioral health. The second being social determinants of health, and specifically nutrition and transportation. And lastly, access to health services. So these priorities reflect both the data gathered and the lived experience from our shared community members. And for each of these, the CHIP establishes clear goals, measurable objectives, and actions that build on community strengths, reduce barriers to care, and promote system-level change. So we'll start to dive into each of those priorities, kind of talk about what some of those action areas might be and what the data behind it to showcase why that was one of the priorities. So in mental and behavioral health, we know that communities, to reach their highest potential socially and economically, people need to feel well at the individual level. Mental health can also have considerable impacts on workforce retention, community engagement, and sense of belonging and connectedness between residents. So one of the goals is to reduce the percentage of residents reporting poor mental health. And some of those action areas we've seen are having mental health navigation gap analysis with 211, collaborate with some community coalitions to connect individuals to the community and resources, secure funding for mental health first aid training and navigation, have community health workers that are certified in mental health first aid, have a shared regional mental health literacy and trauma-informed training, and then be able to share culturally relevant mental health communication to our residents. So the data to support this is from our community health assessment, and this isn't all of the data. This is just some of it that really showcases the importance of looking at spaces and how those impact our health. So the ones I highlight are really the ones that have the regional difference between the county. So the first indicator to pay attention to here, and hopefully you guys can see this, I know it's a lot up there, but it is the percent of fair or poor mental health. So it is lower in our Western Douglas County, which is 17.5%, so the sunshine, that's a good thing. And then if you look at our Northeast and Southeast numbers, we're at 27.5 and 23.2, which are both higher than the metro area average. The last indicator on here is the percent unable to get mental health services in the past year. The concerning part is that we have 7% in western part of Douglas County compared to 14 and 16% in the Northeast and Southeast of Douglas County. Both higher than the combined metro area region. So moving on to the social determinants of health portion, specifically the nutrition aspect. The goal here is to reduce the number of residents reporting difficulties accessing fresh and affordable foods. So some of those action areas could be increasing the navigation and finding entry points to healthy foods, to partner with some local chambers or commerce and attract new grocery stores or mobile markets, culturally specific retailers to the food deserts here in Douglas County. Partner with city, county, and community partners to implement transit route adjustments to improve access to those food resources. And then work on a multilingual food access communication program. So once again, I'm going to leave you with some data, so I apologize. But the indicators on here that showcase really the importance of these is, if you look at the percent worried about food in the past year, we see a drastic difference between West Omaha and compared to Northeast and Southeast. So that is that first one. You see the three sunshines in the western version of Douglas County, and then in the eastern side, you actually see the rain clouds are the ones that are worse than the metro region. The second indicator on here that I think is important to note is the percent that ran out of food in the past year. Once again, we have drastic changes between the western part of Douglas County versus the eastern part. We're comparing about 10.7 and 15% to the eastern parts, which is over 30% in the eastern part of Douglas County. And lastly is our percent of those that are food insecure. Once again, we're seeing very similar story, that looking at 40s in the eastern part, Omaha, Douglas County, and then 20s in our western part of the county. So looking at those that find it very difficult or somewhat difficult to buy fresh produce is hiring the eastern part of the city, and the following map showcases the actual assessment that we conducted of what is available in these areas. So in this map, this is what we call the Nutrition Environment Measure Survey, or so lovingly named NEMS, as we love acronyms. Good. And it's a standardized tool that is used to evaluate the consumer food environment. So rather than looking at what people actually eat, it measures what is available and what's affordable to them at the places they actually shop. So I have two maps here, and I think it's really interesting. The 2018 one I just got on Monday, so I was really excited I was able to incorporate this in here. And I wanted to showcase, so Douglas County has done the NEM study in 2012, 2015, 2018, and then we just conducted in 2024. There was, some stuff that occurred in 2020 that kind of derailed a lot of things. So in this picture, you can see in the assessment, we actually had staff go to all of the convenient and grocery stores that are within Douglas County. I know in 2024, it was over 500 stores. But we go through, look at all these things, and basically rank them on a scale of 0 to 5. So, and it's following up on 3 real pillars of what is looked at in the assessment. Availability, which is the presence of essential healthy staples, really fresh fruits, vegetables, low-fat milk, whole grains, and then looking at the price of those. So there's a comparative analysis to determine if the healthy options are priced reasonably or if there's a health tax, which makes nutritious food more expensive than the processed alternatives. And then lastly, we look at quality. So a point in time check to see if the fresh fruits and vegetables are actually fresh and something you want to eat. Yep. So as you can see in this 2018 picture, we have a decent amount of red in there. You have a couple yellow spots. So yellow is a 5. That's where you're going to see kind of those heat maps and see folks that have more access to those fresh foods, vegetables, low fat, whole grains. So I'll go back and forth because I think it's really interesting to see the difference of what happened for 2018 to 2024. So in 2024, as you can see, there's only really one yellow dot. I'll go back again. There's 2018, 2024. There's a pretty drastic difference in what we're seeing as available fresh fruits, vegetables, low grain, low fat, full grain items that are available to our residents. And even in the northeast part of our city, it's gotten even worse. So something to consider as we go forward, always pay attention to kind of the food deserts as we talked about. The next portion of this is the social determinants of health, the transportation portion. So the goal here is to reduce the number of respondents reporting transportation barriers. And some of the action areas that were discussed are partnering with MAPA friends to develop a transportation map, work with city and county planning departments to expand healthcare transportation, partner with other local planning offices to implement safety enhancements, and then also partner with MAPA to potentially launch multilingual transportation communication plans. So the data that drives this, once again, I'll point out, but we're seeing the same story in all of this data. I'm hoping that I'm kind of hitting home on how place really affects our health. So percent that have a lack of sidewalks or poor sidewalks, we see the sunshine in those western portions and the rain clouds in the eastern part of the counties. Percent that lack trails or poor quality of trails, which prevents folks from exercising. We have in the teens in our western part of the county, and then in the 20s in our eastern portion. Our percent of heavy neighborhood traffic, which prevents exercise. We see 12% in western portion of the county, and then we see close to 30% in our eastern portion of the county. And then lastly, the percent of crime, which prevents exercise in the neighborhood. Once again, you've got western Omaha, and those are under 10%, but yet we've got 30% in the eastern portion. So now moving on to access to health services. The goal on this one is to reduce the number of residents reporting difficulties accessing care. Some of the action areas that were developed are to really build up our community health workers, or we lovingly call them CHWs. As I mentioned, acronyms are important to us, and really building a support network for those individuals. We want to implement a standardized certification and then hopefully train all those new CHWs in that certification. Work on multilingual health access communications. Educate our community members on what are community health workers and how they can be beneficial to your health. And then ultimately really working on funding strategies to help support all of this work. As one thing that I know that has already started to happen in January of this year, a legislative bill was introduced, and that was for the Community Health Worker Training Endorsement Act. So we're hoping to see some good traction on that and see that move forward, because there's a lot of great steps, a lot of great work happening in that portion with community health workers. So back to the data again. On this one, I really want to highlight 3 areas. The lack of healthcare insurance between 18 and 64. We're seeing 5 and below, essentially, in the western part of Omaha, but then 16.5% in Southeast. If we look at the percent that find it difficult to find a physician in the past year, once again, that is looking at 5.5 and 9% in western portion, and then eastern were 16 plus. And then lastly, that I think bridges together 2 of our priority areas is the percent that transportation hindered their doctor visit in the past year. We see under 10 in our western portion, but yet we're seeing 17, 18% in the eastern portion of our county. So what now? I gave you all this data. What am I expecting folks to do with this? So I think this ultimately just showcases that where you live, your zip code, the area of the county really has an influence on our health and how we can move forward with that and ultimately work together to collaborate. So the road ahead. These are all kinds of things that I've mentioned today, but also think that these are areas where we can all work together, and I see a lot of good potential. expansion of mental health support. We could disseminate the mental health communication throughout different areas in different programs. Publish and update a regional healthcare services map. Work to attract new grocery stores and markets in those food desert areas that I pointed out earlier with the maps. And then partner to implement transit route adjustments so that we can improve access to those food resources. Develop an updated transportation map. Expand our healthcare transportation model to those high-need areas. Implement safety enhancements. And then ultimately launch communication plans for transportation and food access. I've given you guys a lot to think about. It's a lot of data. All of our community health assessment data can be found on the Douglas County Health website. And hopefully the community health improvement plan will be finalized, and that will be published hopefully here in the next month. But I want to thank you all for being here tonight, because I think this is really the first step in making sure that health is included when we're looking at place and design of our city and how we can make Omaha a place that we all want to thrive and be in and make it a place that people ultimately want to come to. So I put my contact information on here, my email and phone number. If anyone has any collaboration ideas, please feel free, reach out. I'm always willing to kind of talk and see what we could do.
Thank you, Leah. You never have to apologize for data. I mean, I love it. But, so something that always stands out to me is just the life expectancy gap in Omaha. And I'm always amazed hearing that and seeing that. And it's a perfect reminder of why we have to talk about these things and why we have to make different decisions moving forward. But now I'd like to introduce you all to our panel discussion. So we're going to take this topic and kind of really get into some of these 7 vital conditions and what that looks like in Omaha through this panel from different perspectives. So I'd first like to welcome Dr. Armando De Alba of UNMC, who will be speaking to us tonight from a community engagement health equity perspective.
It's going.
Take your seat.
Thank you.
We have Lauren Cencic with Metro Transit, who will be talking about the built environment and transportation mobility aspect of all of this. We have Arturo Aceves González with LEDC, who will be talking to us about the health equity and the economic development perspective. And thus we have Errik Ejike with NOAA Clinic, who will coming from a direct health services and community engagement perspective tonight. So. Wow, that's exciting. Leah. One more. Take a seat. I'm very happy that all of you could be here tonight, especially because I know all of you from previous work that I've done in public health policy, that environment, and now intersecting with my new role in the built environment. So I'm happy to have us all in the same room tonight. And it's the first time we've all been in the same room in this capacity, which I find really exciting for the future of the city as well. So I also decided to write really tiny because I got cocky with my questions. So bear with me as I read this. But the first question I want to ask to Dr. De Alba. So as we saw, research on the vital conditions framework showed that belonging and civic muscle was at the center. So everything else worked around, and we couldn't really accomplish anything else without that vital condition that's at that center. So communities with stronger social cohesion, where people feel they belong and have power to shape their future, actually have better health outcomes across the board. So from your community engagement and health equity work, what does belonging look like in practice, and why does that matter to health?
Well, first, thank you so much for the invitation, Brooklyn. It is an honor, a privilege to be here sitting with you all, and also learning from you, from each and every one here in the room. We're having a conversation where we all have something to say. I'm here just to share maybe a perspective, but every person here in the room matters, and I look forward to learning from you and with you. So, an excellent question. The very first thing that I would like to share is that as a clinician, as a physician and public health practitioner, there is something I have learned that is very simple, but is also very powerful. Health is often shaped, it's by far shaped by the zip code and by a genetic code. So a lot of things that we see in clinic, a lot of diseases that we see in clinic, particularly I want to mention some examples like hypertension, like diabetes, they don't start in the clinic. They by far, the root cause starts in the neighborhoods. It starts where we live, work, where we play, where we interact with society. So those are the determinants of health. And I think that's a common denominator, one of the common denominators of today's conversation. So when it comes down to belonging, I like to think in a way that belonging is not something abstract or something that is just, is something that it is, superficial. It is actually something that protects biologically to each person. So it's a protective factor. So from that perspective, the sense of belonging also can translate into different ways. Specifically, the first thing that comes to my mind is trust. And we have trust, we're able to engage with our communities. We have to actually think in the way how we can actually protect our communities, and also not only about, ask the question, if we value belonging, but it is also about if we invest in belonging, if we distribute resources in belonging, because that will allow us to actually have a higher impact in our society, in our communities. And one question I'd like to leave it on the table, and again, I want to open this to discussion because I see the room full of experts, people who I respect and admire from different organizations. I don't want to mention names because I don't want to leave anyone on the side. But one thing that I would like to put on the table is, are the policies, policy conversations or decisions we're having on the decision tables impacting, the life expectancy in what way? Are we increasing the gap, or are we reducing the gap for life expectancy in our community? So I think that's one of the conversations we should be talking in this not only today, but also in the tables where we sit and when we have to advocate for our communities, particularly when we talk about Omaha.
Thank you. I love how you bring in trust to that discussion, because I think we all have saw what happens when trust erodes, especially public health, and what that means for everything moving forward. And I'd like to ask a follow-up that you can answer, or someone else can toss, but where in our city then do you see this trust and this civic belonging really playing an active role? I am kind of directing this at you, Errik.
I could speak, good evening, everybody. I'll speak on, when you say play an active role, I could speak of how it plays a negative role in certain communities. So in the North Omaha community, I had the pleasure of being on a grant 3 university that dealt with trust and belonging with our communities, and particular groups. So there were focus groups from African American community, Native American communities, our migrant community as well. And one of the main issues that kept coming up was due to the circumstances that were given and the issues that everybody had faced, which were very different, also similar at the same time. They were, migrant communities very different, but there's been a broken trust in our systems, especially when it comes to healthcare, that simply just have not been addressed to an adequate level. And we just have to be out about that and actually be active in the work that we do. There are many organizations that are actively working in rebuilding that trust, but in rebuilding that trust, then there has to be an acknowledgement from those entities, organizations that broke the trust of the community in the first place. And that's usually the most difficult part. Basically, somebody say, well, we did it wrong. So as we get more partners that have those conversations, and a lot of us are in those organizations and spaces where we can now have more influence and say, hey, this happened. We need to start to do more restorative work, restorative healthcare justice. I think we can start to move the needle to building more trust, and we just have to show up. a lot of organizations have to truly show up in whatever capacity that we use, and that showing up cuts across a lot of sectors. But you just have to be there as in these organizations, be there in the communities to start to rebuild and prepare and to continue to show up, continue to be present, and to continue to work.
Will you keep your mic hot? Because I'm going to ask you another question. In that, in line with that, because I know you have, I'd like you to talk about your Arena and Rhythm Syndicate and kind of what you're doing with educating other people on social justice and public health and the issues that they face to empower them to be leaders in their community, and kind of how that fosters belonging, kind of continues on that showing up you're just talking about.
Yeah, so for those that don't know me, I do a lot of different things. I am all over the place. I somehow am allowed to run an organization and DJ and podcast. It's kind of crazy. Shout out to Omaha. There's a benefit of being here instead of like Atlanta. But with just really quick with the programs that you're speaking of, one of the things I got to do previously at Creighton University, where I worked for about 10 years in kind of the public health field, I was able to use my creative mind and kind of mesh those worlds together of, if I'm in music and I'm in community, I'm impacting youth and I'm around it, how can I tie the world of music together with public health and social justice? So I actually created a class that I actually teach not only in like summer school, but also to different community organizations that use hip hop music and lyrics to educate on different social determinants of health. And what that means, we have conversations about mental health, and I take songs that directly discuss about mental health, use those to introduce the topics to the students. Listen, they break the songs down, and they actually do, I'll call it worksheets and readings that are based in that topic. So we do everything from violence to gentrification. We touch about 14, 15 different topics. And social justice was a big topic as well. And the reason we did that was because I recognized the power of like hip hop music from a lyrical standpoint. It's probably the most in-depth musical genre as far as words go in any other musical genre, just by pure amount of words that are said. So then you find the information in the songs and the artists that talk to these things. It talks about, hip hop can be looked as negative, but it has so much life in it. When you go find the songs and the artists that have something to say. So I just basically bridge those worlds together and to, make a fun class, but a very, very heavy class at times. As you know, some of those topics get very heavy, being in urban communities, dealing with things like even death, and even having to deal with one of my own students being violently killed, So it was a very real in-time program that got a lot of the youth to want to look more into those fields, and also just be open about subject matter that we typically believe they're not open to discussing. So it's helped shape me and impact me personally. And I've been able to talk about that program on a national level as well. So I think the more creative we are in working with our youth to get them introduced to these topics and subject matter in a way, in a language that they understand, the better off we'll be. Instead of running from it and villainizing it, let's incorporate it and bring them up to speed with what we want them to really get out of it.
Yeah, especially since the young people represent the future. So the sooner we can get them belonging and really implementing those, the better the work turns. So thank you. So Arturo, most people might consider health and economics as two distinct things, or might not see the parallels between them. So as head of health equity and economic opportunity, your role, and as a physician, can you help us understand how economic stability, such as having meaningful work or building wealth, can directly shape someone's mental and physical health?
Yeah, and I just wanted to add a little bit about the question that you asked previously about the sense of belonging and how can we ensure that individuals build that trust. And I love what you said. And one of the biggest things that you can see here, I don't know if you've noticed, but in the back, we have the Spanish interpretation, we have American Sign Language interpretation, and that fosters that credibility that we believe, we understand, we acknowledge the expertise that those individuals bring into the conversations, and we celebrate that. And then, as for your question, but I think it's easier if we put an example of an individual that has a job, has a child, and then you force that individual to make a decision between paying rent or buying nutritious spoons. If you're forcing the individual to take a pick, they're gonna always try to get a roof over the head of their families, and then that puts away other determinants, like what about malnutrition? What about other situations? If we had added conditions, for example, chronic diseases like Dr. De Alba was mentioning, a child with asthma, and with what Leah mentioned, I think it was really clear what the map was showing us, and the life expectancy, and then the other social determinants. If you have an individual that's living in the east part of the city, and we take into consideration the historical context of the city, if we know that there was a factory operating for over 125 years, a lead smelting plant that was contaminating the houses that were surrounding that area, if we take into consideration that this family is currently living in a house that's built previous to 1978, which increases highly the risk of that house being painted by lead-based paint, if we take into consideration that that family might not be able to afford nutritious food, like we mentioned, but they decided, you know what, I'm going to take the alternative. I'm going to start growing my own food, but they don't have that education because it's not language accessible. They don't know that their soil is contaminated, and now they're giving their children or their families poisoned food. So we can't take, if we see outcomes, if we see impact in a siloed sense, and we don't see what economic impact is generating on the health of our families. And then for the solutions, well, everything that Leah said.
There is in my share here, an add to the great comments from my colleague, Dr. Arturo. There is this statement I heard from the ADC. I love it, and I'm going to quote you. It's A. Lopez, who we have here, the president from Latino Economic Development Council. Yes, wealth is health, right? And I think that's simple but powerful, and that's something that we should, always keep into consideration. So, like you said, I always been thinking of you when I connect what we call LEDC and related to health, because that's a classic question. It's like, why you as doctors are talking or being part of a group, an economic development group, or being part of these kind of forums, because we need to talk about public health. We need to talk about, how all these health outcomes are related to what we are implementing in our city. And more voices are needed here. We need to also identify what voices are missing. Brothers and sisters from Native American rural communities, elderly populations, etc. So let's think not only just, race, nationality, but also generational. And, I just wanted to put and bring that up for the discussion.
Okay. And I pulled up some CHIP data, board data, and wanted to stress some of, so Southeast Omaha consistently reported worry or stress on rent or mortgage payments, unable to pay cash for a $40 emergency, but without electricity, water, heat, treated as, or even being treated as less intelligent. Very close to Northeast Omaha numbers as well for all of that. So panel, whether it be you two are talking or Leah, anyone, when you see this kind of disparity in Omaha, is it random? So what specific policy decisions, investment patterns, or even historical factors have created and even maintained these gaps over time?
I can start. No, it's definitely not random. If we educate ourselves in historical disinvestment, if we understand the de-jure segregation and the consequences of redlining and disinvestment in this community, especially in the east part of our city, and we know that this communities have been affected historically once and again. We see archives from 1974 where there is physically aggressiveness towards Black communities just because they're crossing a line. They are unable to cross to get a house that's built in more recent years that they know that are not going to be needing reinvestment as soon as the other ones. We understand, like if we go to the construction mindset, if we understand that the materials that we're going to be utilizing to build a house have a half-life, and they're going to be deteriorating regardless of the best weather that we can get in Omaha. We're going to constantly be having to reinvest, and we don't have access to that capital, then that's going to put another strain into the family's well-being in general, not only their physical health, but their mental health. And then, unfortunately, with this pejorative narrative that our current administration is pushing against individuals who are immigrants, who are refugees, and then on top of that, we're affecting directly their mental health. It is tremendously hard for individuals to start seeking out.
Yeah, I would just add to that a little bit too. I mean, it's really about, for me, it's about access. And I think about a lot this in terms of that. We could build the most beautiful parks and medical facilities and schools in the world, but if everybody can't get there, really, who are they benefiting? And so we very much focus on, a lot of these wonderful investments in Omaha, but a lot of them are built in ways and in locations that are not easily accessible by everybody. And so I think about this a lot in terms of not only transit access, but really primarily at its root core, walkability. And so everybody who gets on a bus is a pedestrian first. They're not trying to go from a bus stop to a bus stop. And so when we're designing these places that you are only designed to be able to be served by cars, and that you cannot safely cross the street, and that it's a cul-de-sac, and there is a no sidewalk that does not mean ADA accessibility, you are designing it to make sure that access is really only for those who have a car and have that ability. Not only is it make it uncomfortable for somebody to take a bus or to walk or to bike to that location, but beyond that, you're making it so that, to try to serve it by transit or to try to serve it some other ways is going to be incredibly less efficient in terms of the use of taxpayer dollars and is going to cost twice as much to do for half as many people. And so really, I'm so grateful for this conversation we have tonight, where we're talking about how place and how infrastructure and urban design intersect with all of these things, because to me, it's something I see absolutely every day of how interconnected all of this is as a system.
And I just want to add just a little bit more. You asked about examples as well. I do want to remind everybody, even my definition of health disparity, it means that something can be done. It's not a natural occurring difference, right? So even when we talk about it, our mind needs to go to something should and can be done once we say even the word health disparity, right? And when you talk about examples of, and I'm not going to use examples that are just here in Omaha, but just in general, when we think about Parks and Rec, right? We all know that certain parks look really good and certain parks look not so great. Now, if that's a city-funded initiative, why is there a difference in which parks look good and which ones don't? That should have nothing to do with the neighborhood, income, or not anything, but how are they deciding on what money to put where, right? And you would think because it's city-funded, you would want to take care of everything equally and make sure everybody has the same amenities or similar amenities based on what the parks offer, right? That's just an example, which means certain parks have really nice tennis courts, and some of them, the nets are hanging off cracks in the concrete. And that shouldn't be, just by if you're really thinking about it, because they're funded by the city. You think about in certain districts, just nationally, there are schools that are funded based on the median income of the neighborhood, which means if my mom and dad are poor, I'm going to get less in my school because my mom and dad is poor. That makes no sense. So there should be a change in the law about how do we equalize our funding in schools so children have an opportunity, equal opportunity to get education, access to education, and grow up in, you know, in the same environment as somebody who may live in $1 million neighborhood versus one that the income is 20,000, because the children didn't do anything to affect that, right? So those are examples of things that we have to look at as why they exist that way. We need to do away with it and make sure that the things that should be